51% of people with alcohol addiction smoke as well, or vape as well, and it's projected to continually grow. Right now we see in the literature anyway that smoking is decreased, but vaping is increasing instead. So it's almost looking like a gateway. So like, yeah, less people are smoking, but more people that never smoked before are starting to vape. So among cisgender males that use heroin, they basically use tobacco too, and it's caused tons of death. Right now, it's projected that people that use substance abuse and have other mental health conditions die at least 5 years earlier. But now on top of that, they're dying from the use of tobacco and nicotine versus the initial diagnosis of whatever substance abuse or mental health disorder. So we'll be talking about a lot of things during this presentation, but just for those who don't know, NRT is nicotine replacement therapy, and that is inclusive of patches, gum, lozenges, inhalers, nicotine inhalers, and nasal sprays. Nicotine inhalers and nasal sprays aren't used as often anymore because they aren't covered very well by insurance companies. Nicotine products we'll be talking about is cigarette, chew, vape, pipe tobacco, betel nut chew, hookah. And in the research, when you look back through the research and current research, the word tobacco and smoking is used a lot, but now it's kind of changing slowly because more people are starting to vape, and vaping is not inclusive of tobacco. There's no tobacco in all these different vape products. It's nicotine salts. And the medications we'll talk about during this presentation is Chantix and Zyban. Okay. So this is how it kind of works. Somebody uses tobacco, usually we'll say a cigarette. They absorb it, goes to their brain within 10 seconds. The pleasure centers feels rewarded. They tolerate a certain amount. Most cigarettes have 1.5 to 2.5 milligrams of cigarette. And then they have, withdrawal symptoms, they crave, and then you have another cigarette. And nicotine, they can go usually about 2 hours depending on how much they normally smoke before the craving comes up and gets them again. They have to pick up another one. So we kind of talked about this in the previous slide, but it takes about 10 seconds for any inhaled nicotine. So that's your tobacco, those are your vape pens, to get to the pleasure center and start filling those neurotransmitters and satisfying the person who's using it. Anything else like chew or betel nut chew or anything that's not inhaled takes about 30 minutes to plateau. So nicotine is a stimulant, but in some patients, based on genetics or other comorbidities, it kind of can transition into some sort of a mild sedative or analgesic or a pain reliever as they smoke more and smoke more often. So nicotine affects the same neurotransmitters that cocaine, heroin, and amphetamines affect. So that's why nicotine is more addictive than heroin right now, and it continues to grow. It's metabolized in the liver, so a lot of people, the fact we had up earlier about 51% of people that use nicotine also drink, this is directly correlated to this fact. It is metabolized in the liver, but also because of that, the rate of death is a lot higher in people who use alcohol as well. So the part that's problematic with the DSM-5 in this is that everything in there, including the specifiers, are all related to tobacco. But now we have vaping, which does not include tobacco. So how will we use this diagnosis? And more importantly, will it be updated in the next revision of the DSM-5? So now if someone comes in and they need assistance cessating from this, can we put that down? Can we use tobacco-related disorders in a specifier? So these are current statistics, 17.5% male, cisgender males. And for those who aren't aware, cisgender is people who identify as the same sex they were given at birth. 13.5% of females. There's no data currently on intersex people. Intersex people are those born with ambiguous genitalia. And there is no data on transgender, gender nonconforming, or non-binary people. So these facts here are completely staggering. Um, Depression, they're looking for a stress reliever, and nicotine historically has been associated with that. This is why 50% of the substance abuse um, organizations and mental health hospitals still allow you to smoke on the property. 50% are not smoke free across America. So a lot of times you might be dealing with another substance abuse or more serious mental health disorder, and you're encouraged to go outside and have a cigarette to kind of relax. So again, this is what we kind of talked about earlier about, cigarettes turning into a gateway to e-cigarettes, because some people have the intent of using e-cigarettes in order to quit. When realistically, the companies, the way it's advertised, most people don't know that e-cigarettes also have nicotine in them. So the addiction is increasing. And to that fact, it's very difficult to control the amount of nicotine in vape. The bottles on the side of the vape juice or the e-cig juice will say a percentage or a milligram. But now, since you can control how deep of a breath you take and longer the drag you can, is impossible to determine exactly how much nicotine they're inhaling. Not only that, there are competitions right now all over the internet about to see who can make the biggest plume or do the best tricks. So it's more and more nicotine being inhaled, so more is going through the body. So right now, this is more about age. These statistics are more about age, but this area, I don't know if you can, number 3, the 18% of people between the ages of 45 and 64. This is usually the ages when they're getting diagnosed with diseases that don't go away, like COPD. COPD is chronic obstructive pulmonary disease. And those diseases just progress. Even if you stop smoking, it doesn't go away. You might not have as many exacerbations, but it sticks with you. And usually that disease or complications of that disease will become terminal. So these are all self-reported. So it was a study done, I think, within the last 5 years. And these are all self-reported, that they need to smoke. Like smoking is a necessity, and this is how they get by and deal with the mental health disorders or the substance abuse disorders they deal with. And the people with mental health disorders and substance abuse disorders, they're fueling the economy by being almost 50%. Yesterday, I actually checked this statistic again before I should have changed it on the slide, but it's up to 50% of the cigarettes smoked are smoked by people with diagnosed mental health issues. In Idaho, this number is about 93%, where people have started smoking at the age of 12. And I had a few people in the study I read said it was even less than that. So the tobacco companies, their intent is to get them as young as possible, because the younger you get them, the longer time you have a customer. And that's why tobacco companies have fed into buying stock from the vaping companies. Realistically, at 60, it's not going to be a 60-year-old man that's going to walk in a gas station and say, hey, can I have a bubblegum flavored cigar? They're going to get a pack of cigarettes. So either way, they're making money. The reason this is so important is because a lot of times, especially here in Idaho, if you get caught with these things, they send you to detention. They have another name for it, but they put you through 4 classes in order to get out of training from CDH hired clinicians to talk about nicotine and the problems of nicotine. Half of those people that come to those classes have also diagnosed ADHD or bipolar disorder. Now they're using cigarettes in conjunction with vape. So vape you can use in school. They even have vapor wear out, where you can, it's clothing that has vape inside of it. So a lot of people that have the drawstrings on their hoodies, that looks like drawstrings. It's really something you can put in your mouth and inhale from vape. And then they blow it into their sleeve. Hope you can see me. So the plume won't come out, or blow into it this way. So you can get away with using it while you're in school. So I thought this chart was interesting because it's a big space right here. And I believe that this is a spot where e-cigarettes would once go, almost like the person CDC who made the chart knew it was coming, and that's where it's going to go. But you can see astronomically that mental health, people with mental health disorders towers over people without using nicotine. So again, substance abuse, they just use it way more, trying to deal or to switch out. If they can't get their hands on one thing, let me use that, or use it conjunction together. So a lot of times when people go into inpatient program, they only want to quit one at a time, assuming that quitting the other one would be too stressful. But realistically, all of the research shows if you cessate both things at the same time, you're more likely to be successful with cessating from both for more than 6 months. So this is kind of by district. This is fairly new, from 2017. The last chart that went out, and I took this directly from Project Filter, it stopped at e-cigarettes. So now they're comparing, displaying both the use of e-cigs and regular cigarettes together. So now this is inclusive of people who never smoked before, but decided to use e-cigarettes to try it. So that's somebody who has the beginning of a nicotine addiction. So people with mental health disorders or substance abuse disorders, likely want to quit just as much as the next person. But usually if they're receiving counseling or behavioral health services, they're focused on another issue. And sometimes they're not often asked if they want to quit smoking or stop using nicotine. And people think quitting interferes with recovery from other substances, but just like I said before, research points to the fact that cessating from all substances at the same time is more likely to have a longer quit. Tobacco and nicotine is not as harmful as other substances. This is very untrue. The thing about nicotine compared to other drugs such as heroin and amphetamines and other things is that they focus on the here and now. So for instance, if I had too many drinks and I get a little belligerent, it'll affect people now. You can see it now. If I use heroin or opiates and I nod out, you can see it now. But the effects of nicotine is over a lifetime. So it's more like a long death instead of instantaneously. So less focus is pointed towards that. It's kind of what we talked about, especially during treatment. Nobody wants to say, let me take your cigarettes too during treatment. This one always kind of stands out with me because it's almost unfair to not offer it to them. True enough, in sessions, when you have sessions, you usually have an hour with clients or with patients to talk about the other issues they're dealing with, but there's no time built in to talk about nicotine and stopping to use nicotine. But it's up to us as healthcare providers and behavioral health providers to somehow weave that in. So because nicotine use is higher in places of lower socioeconomic status, they already have a number of disparities mounting against them. And then you have this one too. If people experiencing homelessness, it's especially important for them because it's easier to keep up a nicotine addiction than it is for somebody to give you $1. People will hand you a cigarette because cigarettes are associated with being a stress reliever, but they won't hand them $1. So they can keep this up. This is one addiction you can keep up even living as a person experiencing homelessness. So we talked again before, a lot of people who get over their substance abuse disorder or are managing a behavioral health issue, they end up passing away due to the use of cigarettes or some type of nicotine device. This is inclusive of Idaho as well. You can drive around to a lot of the facilities and notice that they have a box outside for smokers or an area for smokers. Historically, tobacco companies have put up big money to help people fight having tobacco-free policies. And this is true of hospitals, even back in the last decade or so when hospitals were switching over to being smoke-free. There were people battling saying it was their right to smoke and it shouldn't be smoke-free. This is the last chart that was put out as far as facilities, both behavioral health and substance abuse disorder facilities, who have either a smoke-free campus or screened clients for tobacco use. And just, even though screened clients is very high here on the disorder side, it's low for offering cessation counseling. So yes, we asked you if you smoked. Of course, big tobacco. It started it all. They always marketed to marginalized communities. And in this case, we're talking about people with mental illness. So they were big backers of more institutions back in the day where just put patients in them and leave them there and treat them there. And they might have been in it for a longer period of time, but this is where their donations went. This is where Philip Morris sent their donations to support these things. A lot of studies back in the day were funded by Philip Morris and the Imperial Tobacco Company to show what good nicotine could do to help with mental illness. At that point, it wasn't a lot of research because more people were worried about the heroin epidemic, not so much opiates back then, but heroin and other drugs, and not so much the nicotine. So they were backing the ones to say that nicotine is good. A lot of psychiatric facilities, even now, it's not publicized as much, but the cigarette machines were bought by Philip Morris and placed there, and cigarettes were offered at a cheaper price than anywhere else in psych facilities, or free sometimes. So we talked about this before. Both psych hospitals and medical hospitals, when they were going to make everything smoke-free, they were the biggest backers of the people who were protesting it, saying it was everybody's right, they should be able to. So again, with the tobacco companies focusing on marginalized communities, mentally ill, homeless, and LGBT folks were definitely affected by it. The Scum Project, especially in 1990s, those were the people who put on the parties and paid for queer communities in their events because they would put up posters and allow them to come and put tables up and pass out free cigarettes and stuff. The idea is the quicker you get the customer, the longer you'll have the customer. So while people with mental illness and substance abuse disorders can die from an array of things, heart disease is usually the number one, but all of it can be attributed to smoking as well. So yeah, they die about 5 years earlier than people who never smoked. And this data has been continuous over the last 10 years. So when people do smoke, so especially with schizophrenics, sometimes when you go in for a med change, they've been smoking more, so they feel like they're doing better. So the medications start to change, or maybe doses are lowered. But really it's because the nicotine is higher, so they're mimicking the effects that the medicine would. So it's important that when you do get somebody, if you are seeing clients, you do get somebody that's smoking a lot, that the physician is contacted to let them know. So if they do try to cessate, they can normalize their meds to their benefit. So again, this is kind of what we talked about before. So nicotine is being used as a faux medication with these drugs. And people depend on like, oh, I got off, I weaned myself off, but really they've just been smoking more and using nicotine more. So it's mimicking the effects of the medications they were taking before. So what we can do, we can be askers. We can ask the places we work for if they haven't already become smoke free. We can ask for that. We can be advocates for the patient. We can stop smoking ourselves when we smoked, or stop using nicotine, or help somebody else that don't to not to use it. So some facilities, some here in Idaho too, they'll go out maybe during counseling sessions with a social worker or a counselor and smoke with the patient as a congratulations, like, oh, you deserve a cigarette, I'll go out with you, or to continue a session or to dig deeper with the patient and go outside. But it's important that we don't participate when they do use nicotine, that we kind of stay away per se, and encourage that they don't do it without actually telling them, hey, don't do that, but just encourage them not to, at least during those sessions. So although, people with other substance abuse disorders, we are usually focused on that, it's important that we do ask that and try to wrap that into our sessions, or set aside 10 minutes or more to talk about cessating from nicotine as well. Right now, again, like I talked about before, we were worried about the other substance abuse or the bigger problems, but for them, that might be the biggest problem. We can update our intake forms to be more inclusive. More than do you smoke, it should be, do you use nicotine products? Here, the hospital I work at, when I ask them that all the time, if I ask them if they smoke, they'll say no. And if I ask them if they vape, they say, oh yeah, I vape. So they're completely separating it. So it's important that we are specific with what we ask, and keep going forward with that. So much stigma involved with smoking. A lot of us as healthcare professionals and behavioral health professionals don't even want to ask. But it's important that we do, because somebody needs to, and it's likely that they've been wanting to quit as well, and we can help them with that. We can start a nicotine-free group. Currently, there are none in Idaho, but there are many people asking for it. Well, it's important to know, if you do start a nicotine-free group, that it takes a long time to get members. Some of us on the phone can probably attest to that, but still being available to hold the space just in case you get one person is imperative to their success, to know that it's somebody there willing to help with them. So if we can at least give 10 minutes, the rate of quit is higher with counseling and also with NRT, but the 10-minute rate, I don't know if you can see my cursor over here, but that's the number one thing we can do. The 3-minute rate, that's asking, hey, do you use nicotine? Do you want me to help you with it? This was as asking more, getting in depth with it. Again, we usually only have an hour with the patient, and it's tons of things that you likely have to go over, but if you just squeeze in a few minutes to talk about nicotine, that would do them a world of difference. So abstinence rates are directly correlated with the type of counseling they receive. Individual and group are the two highest. Self-help, those are apps like Quitter Circle and other free applications and books you can get. And no format is nothing. So they coming to counseling, coming to any type of session, and never even being asked about it. So it's cold turkey without anything. So more than 8 sessions is optimal for 24.7% quit rate, and this is after 6 months. This is quit ways after 6 months post sessions. Right now, 4% are those cold turkey people, like, oh, I can do it cold turkey, and that is when relapse is the highest. The highest percent is medication and counseling. In this chart, medication refers to both Chantix, Zyban, and NRT. So any version of those plus counseling leads to a higher quit rate. We do use a nicotine-free group. Make sure it's inclusive. You can start it by holding space, or maybe you have access to a free room or free items that they need to have a focus group. And then eventually, if you are not an ex-user of nicotine or a current, to pass it on to somebody else who is, so they can take over the group and be inclusive and be parts of that. Any questions so far? Okay. So now we're going to talk about Project Filter. Idaho is actually really in a good spot because not all states offer this type of program. Matter of fact, Denver is the only other state that offers more than we offer currently in Idaho. So Project Filter, they offer free patches, gum, and lozenges to people who right now use cigarette. It's catered to people who use cigarette because there's not enough evidence about vaping. So how it works is everybody is eligible if you live in Idaho. That's your only requirement, is to live in Idaho and be over 18. So at the hospital I work at, we can sign people up and we fax over a sheet, and they'll make 5 attempts to call that person and get them signed up. After the 5 attempts, they will have to call. If they never responded to Project Filter, they will have to call. With Project Filter, you can get up to 8 weeks worth of products, but in 2 separate sittings. So the first phone call, the first contact you make with them, they'll send you 4 weeks of product, and then you can call back at any time within those 12 months and get another 4 weeks. So for instance, if we're in November right now, you could call and get 30 days worth. And then December, you could call and get another 30 days worth. And then January, you'll be eligible all over again for your 2 months starting over again. It's imperative that when you call Project Filter that you are honest, because how much you smoke determines the milligram that they send you in patches. So with so much stigma involved, some people, I've heard many times, oh, I call and they just sent me patches don't work because they never work. Well, I'm like, well, how much was a milligram? Well, it was 7 milligrams. Well, you smoke 2 packs a day. So that's probably that's the lowest milligram available. So it's imperative that, when you refer people or tell people about Project Filter, you encourage them to be honest on the phone so they can get what they need, and we don't have so many negative connotations associated with patches not working or Project Filter not working and providing them with things. When you do call in, you are able to get patches and gum or patches and lozenges, but not patches, gum, and lozenges all at the same time. Right now, as of this year, they have about a dozen flavors of gum and lozenges, and that's slated to go on next year as well. So with the 5 coaching sessions, that means they'll try to call you 5 times, but you're welcome to call Project Filter. It's 24/7 except for Christmas and Thanksgiving. So you can call as many times as you want. All the coaches are trained to talk to people with nicotine addiction, especially specific to Idaho. Another thing that's nice is that we have 3 different languages of people that can talk to people, and hundreds of others via translator service. So if you speak Spanish or Arabic, you can call in and get the same type of assistance that somebody who's spoke English gets. And the translator service is available too 24/7 as well. With the provider referral, anybody licensed can send a referral over and fax it over. And you can contact Project Filter and they can probably mail you. If you're in Idaho, the person there will probably bring them to you, but they will mail you out things so you can keep them at your office or use them at your office. And these are the rates of quit with Project Filter. So especially if somebody refers them, the quit rate is higher. Additional services Project Filter provides. Right now they have a pregnancy program. For some reason, it's not advertised as much, but they start with a pregnant mother who is smoking and struggling, and they'll give them gift cards and use, I think it's $10 or $5 increments, and they can get it up to 4 months after they deliver as well, to assist them and encourage them to keep calling in. That's provided. The chronic disease program, if you call in, if you have COPD, asthma, or any other chronic disease, the people who answer the phone for this program are trained to tell you what happened with your body once you quit, and what the changes that you'll go through, both good and bad, and vice versa as well. An American Indian program, especially in Idaho, is very important because tobacco is used in a lot of ceremonial things within, based on a tribe. So they'll tell you like ways around that, or inform you of this is why this. A lot of people call in that don't smoke, but they want to ask about a loved one. So they're able to explain that and explain the effects that will happen during those ceremonies. So these are the current products we use. The most important thing about the patches, that please don't cut it, or tell your patients or clients not to cut it to attempt to get more nicotine. They should be placed on the upper part of the body and fatty areas. And when you take it off, to put it back on in a different place. A lot of people don't know, but these products most of them are covered by Medicaid, and some of the physicians don't know. So if you ask for a prescription form, you're more likely to come out of less money when you go in to pick it up, if you have Medicaid. And some insurance is still covered, but maybe not at 100%. It's always worth a try. The worst you can hear is no, and you can just go buy it off the shelves if you're able to. With the gum, the most important thing about the gum is how to use it. We don't use it like a regular piece of gum. We chew it and cheek it. So you chew it a little bit and you get like a peppery taste, and then you put it in the side of your mouth, and then once that taste kind of goes away in a while, you chew it again, and then you put it in the other side of your mouth. With lozenges, the goal is not to bite it. So lozenges, I'll tell my patients to treat it like a Jolly Rancher. The first time you put a Jolly Rancher in your mouth, no one bites it. They immediately put it in their cheek. So you want to tell them to do the same thing and just have them go back and forth, but don't bite it, because it'll just go into your stomach, and then you might have a upset stomach. So Zyban right now, initially it was used in veterans experiencing depression, and I noticed that one of the side effects is that a large amount of them stop smoking. So Zyban can be used. The nice thing about Zyban is that it can be stopped abruptly, and it won't cause the patient any harm. Both Zyban and Chantix had a black box label, and that basically means that it worked for a lot of people, but for a certain number of people that had weird reactions. And that was in place until 2016, when they realized that basically the benefits outweighed the risks. And that's in both people with mental health issues and substance disorders and without. Chantix does not contain nicotine. Both Chantix and Zyban you need a prescription for, and Chantix has the highest quit rates reported compared to Zyban and NRT, and that's as of 2017. Previously, Chantix only had one dose, 1 milligram, so your only option if you had any side effects was just to be taken completely off of it. Now they have the opportunity they have the option to go to 0.5 milligrams to see how that works for the patient. So usually in visits, again, we might not have, if we are not only seeing the patient for nicotine, it might not be possible to use a trans-theoretical model to go through that, with the client, but we can use shortened versions of this to help the client out and set them on the right path. And that shortened version is the 2 A's and 1 R model. So in Idaho, again, we're lucky that we have Project Filter to refer to, and we have is other resources here. I know St. Luke's has a outpatient clinic that we can go to. CDH offers free classes, and there are tons of resources free resources at St. Al's as well. But we can at least take the time to ask them if they smoke, how much they smoke, and encourage them, tell them the benefits and risks of smoking if they want to hear it. And that's the most important part. And then refer them to someone who can help, especially if we are not equipped to help. So here in Idaho, and nationally, these are just some of the resources. CDH and Southwest District Health, they have people specially trained in tobacco cessation, and they'll send out people to do one-on-one classes or group classes if you have a group. The Quitter Circle app is a free site made with, paid for by Pfizer, but evidence is from the American Lung Association. It is also free. If you work at a facility, they are able to get you a code, your own code specific to your facility. So if tracking is important to you, you'll be able to see how many people downloaded the app and used it. Or you can ask one of us. Ask the RT at any of the facilities you use or you work for. And I was hoping, we'll stop for questions, but I have more slides that if we have time, I can get into regarding vaping. Do you have any questions right now? Something's moving. Okay. We'll talk about vaping. So vaping uses nicotine salts versus tobacco, and that is why you don't smell cigarettes. That's why they can put all these weird flavors to it and make it almost appealing, usually to children, but to other folks as well. So all ingredients in a vape pen or e-cig or all the new names that they're calling it now are FDA approved, but just not to inhale. So we are unable to know exactly how much nicotine is held, like we talked about before, because of all the contests and because we can't control what's in the juice. So popcorn lung is the thing we hear the most. The few commercials I've seen that has came out against vaping use that term a lot. And popcorn lung came from a chemical called diacetyl that was in microwave popcorn. And the people that worked there all came down with bronchiolitis obliterans. And so they called it popcorn lung because it happened in a popcorn factory. So our lungs actually don't look like popcorn, but that's why they call it popcorn. Anyway, they took diacetyl out and continued to make popcorn, but unfortunately diacetyl is one of the ingredients in 90% of the vape pens or e-cigarettes that are currently out. And it attributes to many lung diseases. And it's too early for enough research for years to come out with definitive diseases that vaping affects. So how I kind of started out, I started out in China. It was started by a pharmacist. The pharmacist's father died of lung cancer from smoking. That pharmacist smoked. He wanted to stop, so he came over with this thing. So initially it was really used for cessating, and it was actually working for him. And then America got their hands on it, and we kind of commercialized it and sold it to big tobacco, kind of taking over the entire market by 2013. First generation e-cig had 3 ingredients, which is glycerol, water, and nicotine. So again, used for cessating. It looks like a cigarette for the people with the hand to mouth that had to do that part, and it was kind of used just for that. It still tasted like nicotine. It wasn't any fruit flavors involved. Second generation, this is when the flavors kind of get in and the colors and start to appeal to more children. Third generation, they start adding mods and pods. This allows them to take bigger puffs and have more nicotine based on power. So a lot of these take different size batteries, and they'll be able to take bigger plumes or add more juice. The fourth generation is by far, for me, the most dangerous. This is the generation of the Juul. So the Juul are these that look like flash drives. And some of the children I've spoke with, they said that the best high they get is when they drop it and the teacher picks it up and gives it back to them, knowing that it's a vape pen and not really a USB drive. To get a starter kit of one of these is $40, and it comes with 5 cartridges, nicotine cartridges, or 4 or 5 nicotine cartridges. And then after that, you can get them, depends on where you buy them from, a cartridge from $2 to $5 a cartridge. Main ingredient is nicotine. What's important about vaping is that the liquid, if ingested or put in your tongue, it can be fatal. And this is especially important because of children. They like to lick stuff and put things in their mouth, and the juice from that could be fatal for them. And these are just some side effects. So propylene glycol, that's the main ingredient in antifreeze and one of the main ingredients in vape pen too. So currently all those people are inhaling antifreeze. Glycerol is something else that's used in cooking. Again, FDA approved, but not for inhaling. What's interesting about propylene glycol is in a lot of our foods like ice cream, but it's okay at that temperature to ingest it. It's once you inhale it, it becomes dangerous. And benzoic acid, that's something that you find in like things like Neosporin. But for vaping, it makes it a lot smoother. It makes the drag a lot smoother, so your throat won't feel like it's burning all the time. And these are some other ingredients inside of vape. This is the diacetyl closer to the bottom. That's the ingredient that was inside of the popcorn that caused popcorn lung in those workers of the factory. And this is my last slide. This is called Puff It. I just found out about this about a month ago. But this one looks like an inhaler. And again, the kids love when the teacher picks it up and hands it back to them. What's really dangerous about this is that not only can you vape, it's juice that you can use for that, and it'll vaporize that juice. But it can also vaporize the wax marijuana you can put in here. And kids have been caught doing that as well right here in Idaho. That's it for the slides. You guys have any questions? I'm trying to go back to the slide with my information because somewhere. Oh, here it is. Please feel free to reach out to me at any time if I can help you with anything or you want more information, and I'll make myself available.
Well, thank you so much, Gabrielle. Yeah. I can't believe the inhaler one.
Yeah.
That's horrible.
Yeah, that one kind of bothered me the most.
Mind-boggling, but well, thank you so much, Gabrielle. I really enjoyed listening to that, and I hope you all did as well. If you have any questions, you can feel free to ask now while I'm kind of closing things up, or you can email Gabrielle at the email she's provided. So a few quick things. We have our webinars and all of our newsletters. So if you would like to register for our newsletter, you can go to www.empoweridaho.org, and there's a sign up button up there. Yeah, so there's going to be an evaluation that pops up when you exit out, and also it will be emailed, so you can access that at another time. Evaluations are super helpful for us, and we can kind of figure out what people want to learn about in the future. Yeah, so thank you again, and thank you, Gabrielle. And yeah, we hope to
Thank you.
Join us next time. Okay, bye everyone.